Alrighty, and I can see that the participant list is going up, so people are starting to join. If you're joining, welcome. I'm Caitlin, a member of the Communications Committee, and we'll give some time for people to join, and we'll get started in a minute or two. Looks like we've got about half of our registered attendees, so I'll just give it another minute to see who else files in. All right, I think we can get started now. So for those who joined a little bit later after I introduced myself, I'm Caitlin, a member of the Communications Committee, and today we have a great webinar with three awesome panelists, speakers, moderators. Just so that all the attendees know how the Q&A portion will work, you should have a Q&A button right at the end of the bottom of your screen, and when you click that, you should be able to enter any question that you want to ask our group. It will not be anonymous, so your name will be attached. And the group, our moderator, Tom, will be able to choose which questions make sense with the flow of our talk. And me and another member of Communications Committee will mark questions as either answered live or we'll answer ones in the chat if we're able to. So yeah, now I'll give it away to our awesome speakers.
Well, thanks, Caitlin. I'm Tom Insel, and I'll be the moderator for this conversation. And just by way of background, the topic here is data and milestones, one that I think is really just a great place for SDMH to focus. I was given the honor to serve as a co-chair for a group last year that the Kennedy Forum organized on just this topic. And we spent about 9 months with lots of leaders of different health plans, payors, providers, and some nonprofits, really thinking through where are we? Why has it been so difficult to go from fee-for-service to value-based care? What do we actually mean by value? How do we measure outcomes? What is the best way of understanding quality? And I think we kind of floundered until somebody recommended that we bring in this group that had developed something they called precision behavioral health, precision digital behavioral health. And we, in that moment, I think really found our North Star. So I thought it's great that we can have all of you share that same moment and get a sense of where the promise is, I think, right now, and hearing from a group that's actually done this in a really, really smart and effective way. And that's what we'll be doing over the next 45 minutes prior to taking some of your questions. I thought it might be good to start with first just introducing the two people who have built this and getting a sense of how they came to it. We'll talk a little bit about what we see as some of the problems that had to be addressed, and then really jump into the solutions. So maybe we'll start with Georgia, who's joining us from UHS, Georgia Hoyler, who's been part of this really from the beginning.
Thank you so much, Tom. So I'm Georgia Hoyler, or Georgia Hoyler Haynes, and I am currently a Vice President of Clinical Product Strategy at Equip, which is a digital behavioral health provider providing eating disorder services. But prior to making that switch to Equip in the recent months, I served as a vice president of product innovation and strategy within United Health Group's corporate office of strategy and innovation. And I was there for the better part of a decade, spending time focused on organic development of new products and services that United Health Group could launch either as an offering within Optum or an offering within United Healthcare. So while I did not sit within the United Healthcare plan, I was very focused on building business cases for investment that aligned to the needs of both our our payer entities within the UHG footprint of Optum Behavioral Health and United Healthcare, and also the needs of payers outside of the UHG umbrella. So that's the perspective that I bring to both the work that I partnered on closely with Sam, and also the broader work of other products that I've worked on in that capacity. So excited to be with you today.
Great. How about you, Sam?
Thanks, Tom. I'm Sam Nordberg. I'm the current chair of Psychiatry and Behavioral Health at Reliant Medical Group and Atrius Health, organizations with a decades-long strong history of value-based care. So at both organizations, more than 50% of patients are either fully capped or in shared capitated arrangements, which mostly include behavioral health risk up and down. And I've been sort of between those two organizations for about the past 12 years. Prior to that, I was at the VA for several years. And prior to that, my first career was actually on Wall Street. And so I did a lot of work modeling tech companies and building analytics and predictive models. And a lot of my work sort of mirrors that predictive modeling in Wall Street, really trying to find, collect, and use data to prove what I already know, which is that what we do has tremendous value. And I hope that one of the themes you'll hear throughout this talk today is that relentless focus on data, because I think it is both hard and absolutely critical for our success as we try to build novel models of care for our patients. I'll stop there.
I think that's a great place to anchor this conversation. And if we sort of back up a little bit and say, what's the problem we're trying to solve? My own perspective on this is that we're looking at a kind of tale of two cities. On the one hand, you've got incredible potential with hundreds of companies that have been born in the last 5 years, $12 billion of investment in digital mental health since 2019. It's just stunning. It's unprecedented. The advent of tools like AI and all kinds of ways of collecting data at a scale we couldn't even have imagined a decade ago. That's one city. The other city is you've got the worst of times. You've got a mental health crisis that plays out in higher rates of suicide, 52% in adolescents and youth. You've got people with serious mental illness who are dying 23 years early and not doing well in the mental health care system, most of them not even engaged. And you still have a substance use disorder epidemic with nearly 100,000 deaths a year. So the public health numbers, the outcomes are terrible, and yet we've had this entire revolution in this field of being able to provide services that are more convenient, more accessible, and in some ways democratized. My own read on this, and I'd love to get both of you thinking about what is the problem that needs to be solved here, is it does track back to what you were just saying, that I think a lot of what we've done in this world of venture-backed startups is to say, let's improve access, let's make mental health care more convenient. What we haven't done is to say, let's make mental health care better. Let's make it higher quality with the data to demonstrate what that quality looks like. And so I would argue that if you make it easier to get access to garbage, that's not progress. And in some cases, I'm afraid although it's difficult to know because we don't have the data, that that's exactly what we've done. I'd be interested for both of you from the side of where you were sitting, Georgia, in the world of a payer, as well as where you were, Sam, in the world of a provider. How do you see this last 5 years? Where's the problem that we need to get to in term where data and milestones can actually make the difference? Maybe Georgia, we'll start with you.
Sure. So I think from the payer perspective, you mentioned, Tom, that there has been this, increase in access, and certainly payers have felt an incredible amount of pressure to respond to that demand for increased behavioral health care access. I think that the effects of having an insufficient network has meant that we have observed, historically and kind of artificially limited network-based usage that suggested that that was actually where patient needs were, even though we knew that that was not the case. And so as payers have recognized this burning need for more services, they have done really a heroic effort of trying to increase participation of behavioral health providers in the network. That has, largely taken a few forms. One, it has meant contracting with network aggregators who have promised to increase access through the work that they've been doing to recruit more time from small practice providers that might have otherwise been practicing largely independently and on a cash basis. And they've also had to offer more premium pay to get some of those cash pay providers to come into their network and consider a insurance arrangement. Both of those factors have increased the cost of treatment per patient. And research calls that I was doing with payers just a year ago pointed to between a 12 and 25% increase year over year in outpatient therapy spend between years 2022 and 2024. And so one thing that certainly has held true and has been a pain point for payers is that as they have increased access, they have seen this immediate adoption and use of that access in the network. Once again, kind of then creating the need for even more access, but without any clarity on whether the amount of access that they've generated is the amount that the market needs, and also whether how to manage that increased cost against some set of standards around right patient and right time. So I think the first challenge to kind of put a point on it from the payer perspective is we see the potential for runaway costs without having clear sense of when we will hit the equilibrium of actually getting all of the patients who need care connected to care. And we can't expand access indefinitely without having a better sense of whether the patients who are getting to the front of the line are the patients that need it, unless we can somehow lower the unit cost per treated patient. And ideally, not just lower the cost per unit per treated patient, but really lower the cost per improved patient so that we're putting our dollars towards the highest quality care that those dollars can get. So I'd say that's the first payer pain point and need. The second is around this question of leading indicators of change and how to evaluate quality. I think with diabetes, there's a very strong and accepted relationship between an A1C and the treatment that a patient is receiving. If we're seeing that it's doing a better job of managing glucose over time, then that's likely a therapy that's worth paying for. There isn't a similar leading indicator that has a clear relationship of if we can see this clinical indicator change, we see this impact on our total cost of care. And I think building that kind of leading indicator is a critical need for behavioral health so that payers have a clearer sense of how to assign a value to the efforts and treatment models that are proliferating both in digital care, but also in brick and mortar care models that are provided. So I think that has to do more with the kind of data and visibility. And I think the third problem that we were focused on solving was to say, how could we articulate a theory of the case around around impacting total cost of care. So not just what indicates high quality care, but also what is the downstream impact on that population health story that we want to make impacts to. And I'd say that there's been an increased recognition that the presence of a behavioral health diagnosis increased the costs of patients who compared to patients with similar medical diagnoses in the absence of a behavioral health diagnosis. So I think often referenced in calls with payors were the results of 2 Milliman reports, the most recent one, of course, released in 2018, which focused on conducting claims across commercial, Medicare, and Medicaid patients. And what they were comparing there was what was the difference in per member per month costs when looking at patients with a similar medical profile, so patients with asthma, for instance, and then comparing if they had that behavioral health diagnosis versus if they didn't, and how that PMPM expense may have further increased for patients with more severe medical diagnoses. And what they found, and then validated with an updated study in 2018, was that on average, even after controlling for the medical diagnoses present, patients with behavioral health diagnoses typically cost 2 to 3 times that of patients who had the similar medical diagnoses but no behavioral health costs. So on one hand, there was a recognition that behavioral health is adding to the complexity and the overall cost required of the insurer to manage that patient. And yet there wasn't an answer for how much of that cost, that incremental cost, could actually be captured through some kind of improved treatment or early identification, treatment, and ultimately kind of resolution of the behavioral health diagnosis. So I think there was an understanding that of the potential for cost savings, but a lack of a strategy for how to potentially measure and capture that cost savings potential.
That's great. We want to bookmark this point because I think probably everyone on this call has seen the Milliman data. Obviously, there's an increase in costs. The question is, does the intervention bring that down, and how so, and what part of it really matters? So
Right.
what part is worth paying for? Sam, moving from cost to care, from the provider's perspective, where are we? What do you see as the pain point that you were
Yeah, so
after?
I was gonna say the same thing that you just did, which is, no one questions that co-occurring behavioral health adds cost and, importantly, burden. Right. So Reliant and Atrius are primarily primary care organizations with more than 1 million patients. PCPs are our lifeblood and our culture. And the impact of co-occurring behavioral health on primary care physicians who are unsupported is profound. So no one questions that cost, especially on the provider side where it's felt keenly. But as Tom said, confidence in our outpatient interventions is low. And in no small part because we don't collect data and we don't do the work required to match up our interventions with fundamental changes in how patients utilize care and how they feel and how they function. And so, from the provider's perspective in value-based care, your goal is to keep your patient population as healthy as possible in order to keep them out of the emergency department, the hospital, and manage them as proactively as you possibly can. Because the general principle is that upstream interventions can then divert the patient away from later higher cost inpatient interventions. So by the end of the pandemic at Reliant Medical Group, which has about 350,000 patients in primary care, we had more than 3,000 patients on our waiting list. And this is a really important take home, I think, for policymakers and for those making arguments around behavioral health care quality, which is that the standard of care in the United States of America is not psychotherapy. The standard of care is nothing. More patients who have a behavioral health diagnosis and seek care get nothing than patients who actually get psychotherapy. And when patients get medications, often those medications are prescribed by their PCP, and the efficacy of medications is pretty low. And so the current state is both that there isn't enough intervention for a value-based care organization to get upstream and empower their patients with interventions, and the interventions that currently exist aren't great for most patients. And so that creates a tremendous amount of waste in a system. And those, 3,000 plus patients on our wait list, that's an uncontrollable cost. We had no way of intervening to do something for them in order to manage their health and get them better. And so the key question that we started to ask ourselves as providers was this: it is not a question of access. It is a question of access to what or whom. And if you are trying to give everybody access to psychotherapy, when only about 40% of patients who engage in psychotherapy actually make clinically significant improvement, you've wasted the time and effort of 60% of your patients. We can do better than that if we can start to think about other avenues for treatment, right? Ranging from you need a dog to you need an app. And we decided to start with apps and digital technologies because they were scalable, they were replicable, and they made for a relatively easy thing to study.
So Sam, I'm
But
going to stop you there because we're going to unpack that in just a moment. I'm trying to
Yep.
understand that you both identified some pain points, and I got to say those are pretty compelling pain points, right? Whether it's the increase in cost or 3,000 people on a waiting list, there's obviously huge demand, huge costs driven by that, and frankly, funky outcomes for everybody. Like nobody's happy here. The payers, the providers, the patients, the families, everybody's unhappy, which is a wonderful opportunity for innovation. I want to hear how the two of you got together, because like in this world that we live in, payers and providers don't often get together to do something interesting. So how did that partnership happen? And what's the origin story here?
Well, so one of the wonderful things about being a part of Optum Care is that you get access to all the different parts of Optum and United Health Group. And so toward the end of the pandemic, I had this idea. We actually still have the napkin on which it was sketched. And I'd started pitching it. I just pitched it to anyone who would listen. And one of the folks who worked in Georgia's division of UHG heard the pitch and reached out and paired us together. And I'll let Georgia take it to the next part of the story.
Yeah,
But I will
Georgia.
say
Well, the thing
one
about
key
this,
thing that I was
yeah.
pitching that I think is really important. One key thing that I was pitching was our existing ability to collect high quality data. One of the first things I did when I joined Reliant was I built a practice research network, which is a research, high university quality research lab within our four walls that could do high quality publishable research. We collected data on our patients routinely, and we had built that in. And it was a critical part of the pitch. I think if I hadn't had that, the pitch would not have had the sort of garnered the respect and the attention that it did.
Yeah, I feel like we're asking about your first date here because the way you describe this. But Georgia, what was the investment thesis? Like, how did you say, oh yeah, this is worth putting some sweat equity and some real equity into it?
Yeah, absolutely, Tom. So I had been, in parallel to the struggles that Sam just articulated, he was feeling acutely at Reliant and Atrius. I was focused on capturing those problem statements from payers and also from this increasingly complex network of care providers to try to understand what are problems that make sense for UHG's innovation teams to be spending time on around medical behavioral integration. And I had arrived at the conclusion that we needed to have some kind of model of care that was going beyond a typical collaborative care model, recognizing that that is not a treatment model for all patients, and that it does not solve the access problems that we were describing by itself. And so I was focused on developing theories of the case that I could then bring to payers to kind of test for feasibility, that were focused on lowering that unit cost per treated patient, introducing some kind of measurement-based care mechanism that we could use as a proxy for quality, and thinking about deploying it in a value-based care population so that we could eventually build a business, build a data set big enough to prove the relationship between clinically significant behavioral health change and that total cost of care story, to understand how much of that delta that Milliman and other studies had showed really was capturable. So I knew that I was looking for a solution that needed to check those boxes in order to solve the problems articulated by payers, who would ultimately be a target funder for some kind of program like this if we sought to have it as part of an insurance network set of benefits. And when Sam came to me with this idea that we ended up calling precision behavioral health, it felt like a perfect puzzle piece of a thesis of what that solution might look like. And so the focus of the proposal that I put together to an innovation council at United Health Group was focused on a milestone-based funding approach to de-risk the questions that needed to be proven in order to trust that the model that we'll walk you through in a minute had legs. And largely that came down to, if we're going to, the first milestone was, if we are going to embrace the potential for scalable digital interventions as part of the ecosystem of therapies that we want to consider for behavioral health patients, how can we prove that they will be used and acceptable to both referring providers and to patients? Once we've done that, how can we think about proving the scalability of a model beyond an initial site? And then third, how can we make sure that have a big enough data set to evaluate the questions of total cost of care? And so we essentially laid out both a hypothesis for what the care model might look like, as well as a staged investment thesis to de-risk the investment that might be required to fully build out that program into smaller bite-sized increments, where we'd have clear data to support each phase of that work. And that was a convincing enough proposal to allow us to stand up a pilot of the envisioned model at Reliant, and then expand to Atrius Health as well across a period of a few years. So I know we haven't described exactly what the solution is, but
let's do that.
largely
Why don't we jump in and actually show
Sure.
people what it is we're talking about? And Sam, do you want
Okay.
to take us through this and kind of give us a quick tour of what you built?
Absolutely. I'm going to share my slides.
And what I'm going to ask you to, I mean, obviously you can take us through the model, but what we really want to know is, does it work? When does it work? When does it not work? What do we need to know about the good,
Yep.
the bad, and the ugly?
Yep. Let me just start the slideshow. There we go. Okay. You should be able to see my slides.
Great. We got it.
Yeah.
All right. So the key around this system and methodology is it has to fit within existing clinical routines, and it has to do so in a way that is as seamless as possible. So I think it's important to call out that the first person we hired when we got funded was a fabulous senior implementation scientist, because great ideas go to die in the implementation of those ideas. And so what I am presenting today looks nice and clean and neat. For a period of about 18 months, this really felt like a startup. People were wearing a whole variety of different hats. We were learning a ton. We were making lots of mistakes and learning from them. It was a heady, sort of wonderful time. And so what I'm going to review, I want to be clear. This is the product of this sort of tremendous dynamic team working together and allowing ourselves the space to make all sorts of mistakes and learn from them. And the reason we could do it so fast is because we were collecting the right data, and we had a team internally who were calculating and crunching those numbers on a weekly basis to give us rapid updates on whether the hypotheses that we had were panning out. Right. So with that process, that sort of learning health system model, this is what we came up with. Right. So first is an ecosystem of digital mental health interventions that includes some interventions that have been proven out, meaning that they have been used with hundreds, if not thousands of patients. We have outcomes data on them. We have utilization data on them. We have a long-term partnership with their leadership teams, and we have a high degree of confidence in those solutions. And then there is always a rotating group of solutions that are being tested. And so right now, the ecosystem is on the order of sort of a dozen different tools. Many of those tools are sort of what we would call hardened. Some of those tools are tools that we are putting into the ecosystem to test how they do alongside the other tools. And this was designed because we knew that new tools would be coming. And the ecosystem approach allows us then to cast a wide net, so that if a tool turns out to be applicable only for 8% of the patients we're triaging, that's terrific, as long as I can identify who the right 8% are. And I'll get into that. The last key piece
just
about
to clarify, what you're calling
Yeah.
tools would be like, is Equip, an example of a eating disorder?
So it's either FDA cleared or consumer facing sort of wellness technologies. And they run the gamut from virtual reality, app-based, device-based, biofeedback, right? We wanted to cast a very wide net. So we did not restrict ourselves to FDA cleared technologies, but we did require every technology to go through two different review cycles. So one was a research review cycle where we reviewed all their published and unpublished research on outcomes, in particularly looking for evidence of doing no harm relative to standard treatments today. And then the second was a clinical review where a team of expert clinicians kicked the tires on demo after demo after demo. And we reviewed more than 400 different technologies to arrive at the ones that made it into our ecosystem. And less than half of the tools that are in the ecosystem end up being hardened and staying in the ecosystem.
Got it. Okay.
And I will just add, Tom, that because we were so focused initially on how we could scale access for the patients that present most frequently in primary care settings, we were focused on solutions that were addressing the lower acuity presentations that were most often the ones being triaged and then waitlisted. So more of the mild to moderate anxiety and depression presentations, rather than presentations that require kind of specialty behavioral health teams like Equip's model. So that was a kind of later enhancement that was focused on virtual delivery of care through behavioral health providers that still had a focus on visits and sessions. This first phase was really oriented around more scalable digital first mental health interventions.
And it was adults only or children and adults?
18 plus.
Got it. Okay.
You had to be able to consent to an end user licensing agreement.
Cool. All right.
And worth noting here that as the ecosystem grows and we grow more confidence, we have started looking at other tools and looking at moving into the more moderate severe area of need. And we'll continue doing this work for as long as we have the privilege to do so, and evaluating novel technologies as they come into our awareness. So the key of matching the right patient to the right tool is phase 2, right? So phase 2 is our measurement must be as complex as the patients who present to us in primary care, meaning that we could be seeing everything from subclinical anxiety all the way through to severe mental illness. And we need to be able to rapidly determine the differences between those patients. So between Reliant and Atrius, we triage roughly 75,000 patients a year. The only way to do this at scale is with some kind of a data-driven approach rather than a clinician-driven approach. So what we use is a multidimensional screener. It has 18 different subscales. It starts with just a few questions, and then as you answer those questions, it identifies those areas that are of clinical significance for you, and it stops asking questions about the areas that are not important. And thereby, it keeps itself relatively brief, but it also tailors itself to the particular patient, allowing us to capture reliable, valid data, but we could do so on a patient with PTSD as easily as we could do it on a patient with bereavement. Right? And the way that the different subscales are elevated for different patients tell us the constellation of symptoms that make up their current need. And, we could call those diagnoses if we wanted to. We could call them, constructs, but the key is that the multidimensional data allow us to tell the difference between different patients. And we have identified dozens and dozens of different patient types using these data now that we've collected more than 10,000 patients worth of data. So the patient completes this measure before they come in for their primary care or their behavioral health appointment. And then in the background, a clinical decision support tool is using that precision data to recommend the top 3 apps that are most likely to be applicable for that patient, or to determine that that patient is out of scope. And if the patient's out of scope, then the clinician just moves on with treatment as usual. If the patient is in scope, the clinician gets a pop-up in the electronic medical record. They click through that pop-up and they get their 3 recommendations. They review them with the patient. They can then click just with 2 clicks and they've ordered the technology. The next and last part is one of the things that we learned the most rapidly, which is that lots of patients will say yes to their PCP or their behavioral health clinician, but then when it comes time to register, download, get on the tool, unpack the virtual reality headset, we lost tons and tons of them to follow up. So we created from scratch the role of a digital care navigator. These are folks we hired for charm and trained on everything else. I think George has heard me use that phrase for 4 years. And they are basically there to be super familiar with the tools, knock down technology barriers, and help patients get started. And right now, when a patient meets with a clinician, agrees to a tool, that tool gets ordered, and the patient is on the phone with the digital care navigator within 24 hours, we get 96% of patients registered and started on the tool that they selected, up from under 30% without the digital care navigator. And then lastly, we have check-ins with clinicians, either PCPs if they opt in to check in with the patient themselves, or with a behavioral health clinician. This gives us eyes on to the patient. We collect additional data at that time, subjective data from both the patient and the clinician. And then we collect every 2 weeks that multidimensional assessment on our patients so that we're building a longitudinal data set that we can then use in real time to evaluate tools as patients are going through them, and to identify patients who might be off track, meaning they're not getting what they need out of that tool, and we need to mix up their treatment. Let me stop there. How'd I do, Georgia? I think you wanted to talk a little bit after this about.
Yeah, so I think that, the model that Sam just described is the model that we had originally presented to the Investment Council with a specific ask of what would be required in order to launch an initial pilot of this solution as described. And our first focus was to prove that we could get a sufficient number of patients to accept a digital alternative to therapy, which they were often expecting as their referral outcome, and that we could also see sufficient rates of willingness to recommend from clinicians, both primary care and therapists, recognizing that the entire model hinged on clinician buy-in and willingness to consider things that were not the kind of previous standard of care. We were able to prove both of those within the first year of launch. And then we focused on that second question of how we could scale the number of patients who could be eligible for these kind of programmatic interventions, and also how we could scale the rate of referrals into this model by standing up the clinical decision support mechanism in primary care, so that these referrals were no longer dependent on behavioral health triage teams double checking the recommendations from clinical decision support. So both things that were focused on kind of those programmatic components that we know we needed to prove, and also allowed us to scale the volume of patients enrolled in the program, which would be essential to improve the total cost of care claims that we wanted to ultimately get to.
So let's jump into that. I mean, there's some questions coming in that we're going to want to get you guys to respond to in a minute. But I think the big question is, does this work? And what was the result of putting all this in place?
Yeah, so let me see if I can be quick, because I definitely want to make sure we get to questions. So does it work? So in terms of timely access to care, absolutely, right? We basically double our referral completion rate. We absolutely crush the wait times. And then when it comes to looking at clinically
Sorry,
significant
Sam, but
improvement,
the control group here, network-based psychotherapy, what is that? What's the comparison?
that is when we refer a patient out into insurance networks for care.
Okay.
So
As
said
opposed
another way,
to precision
yes.
behavioral health.
Exactly. Said another way, we had more visibility into what was the actual treatment timeliness and rate of patients getting that first intake visit following a referral in network at Reliant than we would get if we were just looking from a payer lens, because of Reliant's data on both the referral action as well as claims data on their at-risk population, which allowed us to do that kind of comparison of what is the standard when patients are referred into network for care versus what is the standard that this model could deliver.
Cool. Okay.
And so, just to remind folks, patients who did get a visit got it on average within a month, but only 43% of patients that we referred out got a visit. Right. And then in terms of clinically significant improvement, this is the piece that surprised us the most. We were gunning for parity. And what we got was a very significant bump in clinically significant improvement. Now, I want to be very clear. This is not an apples to apples comparison, right? That 38%, which we used from a meta-analysis by Kuipers, that is across a patient population that likely includes moderate, severe, maybe some severe patients. And so that 64% rate that we get is for the patients that we have cherry-picked for the Precision Behavioral Health Initiative. So I want to be clear, it's not an apples to apples comparison, but that doesn't matter. As long as I can identify which patients are the ones who benefited and get them into that digital route. Right, then I can sustain that 64% improvement rate for all of those appropriate patients. And I could talk quickly about that, Tom, and then we can, from a systems perspective, it'll take me 90 seconds, and then we can move on to questions.
Yeah, let's do that really quick.
Okay. So real quick from a systems perspective, in 2021, if you look on the left side here, Reliant, which is where this was built, we were treating internally, right, about 72% of our patients' needs, referring out 21%, and then there was a hodgepodge of patients who were, quite frankly, lost to follow-up, another 7%. Fast forward to after the deployment of Precision Digital Behavioral Health, now 31% of patients that we triage are getting triaged directly into digital tools. 13% are getting referred out, and 52% are being managed internally. This is important for a couple of reasons, right? I have the same number of clinicians internally in 2023 as I did in 2021, but they're treating fewer patients. This allows them to dedicate more resources to more complex patients who need them and need their flexible approach, but only because I was able to siphon off a third of the triage volume into our Precision Digital ecosystem. Right. We also reduced our reliance on the insurance networks during a time when our total patient volume of need was going up pretty substantially. And so from a systems perspective, this is getting me closer and closer to the ability to manage the needs of all of our patients. Right now, we're triaging 83% of our patients into a treatment arm that we own. And that gives us a lot more control over those patients' outcomes and over their needs.
I got that. So, but to keep you honest, I've got to ask Georgia. And now Sam's telling us he's got lots more people coming into treatment. Now it's within Reliant or Atrius. But what does that mean from the payer's perspective? Is this saving money? Are you spending more money? What does it look like in terms of the ROI?
So in this case, Reliant and Atrius are serving as the payer because they are, they are an at-risk entity. So I could put it back to Sam, but in short, this is a compelling story for whoever the at-risk entity is, whether that be a payer or a sub-delegated provider organization, because it has shown that we can scale access with a much lower unit cost. And furthermore, we have better data on most of the patients being treated at Reliant because they are being treated through a measurement-based care model. We know that we're getting that data showing clinically significant improvement for the 31% of patients being treated through the precision behavioral health model. And there was already a standard of care that involved measurement-informed care for the 52% who are being treated by internal staff. So we both have better data visibility, lower cost per treated patient. The other factor that we were looking at in parallel to this health system story was to say, do we have confidence that even as we divert patients who might have otherwise just been referred into insurance networks to a digital alternative, that we aren't just delaying a later referral to therapy. And so we analyzed the therapy network usage among patients in this precision behavioral health program to make sure that we were aware of any services that they may have sought on their own outside of a formal referral from Reliant. There's nothing stopping them from still, seeking a therapy intake through their insurer. And so we were able to evaluate, is the service being provided through that digital intervention sufficient such that they are not pursuing additional behavioral health services? And the early data there was also promising, showing, yes, we were serving as the primary intervention for the behavioral health needs of those patients, which only reinforced that we were in fact able to capture that lower unit cost goal that was kind of the part one of the two-part story here of lowering unit costs and then ultimately reducing the total cost of care.
And on that part two, do we have data that says you were able to bring down total cost of care?
So
we don't.
Sam will have to give the latest. What I will say at when I had left 6 months ago is that the run out time required across the patients enrolled meant that we hadn't yet gotten to a volume of patients and controls that would allow us to look at that. There's so much variability in year-over-year costs that we were still in the mucky middle, needing more volume to be able to prove the total cost of care impact.
That's where we are exactly. The claims delay and the amount of data required to control for all of the different shifts from year over to year. We aren't quite at the massive data set yet required to do those analyses, but we are absolutely closing in on it.
Yeah, so it's going to be important to hear about that.
I mean, it's the most important, right?
But if there are questions coming in from the audience, I want to make sure you have a chance to look at those. A question from Jeremy Alterman about what kinds of barriers do you see in scaling this model of care to other providers and communities, especially ones that may not be capitated? You had this unusual situation where 50% of the people were in a risk-bearing arrangement. Can this be scaled elsewhere?
So right now there isn't an easy fee-for-service pathway. There is starting to emerge one for FDA cleared technologies, and we are working on making sure that we're evaluating most of those technologies so that if we need to, we could, for example, create a more limited ecosystem of FDA cleared technologies. But the way that we have been sort of pursuing this is, sort of case rate agreements with individual payers and working up those conversations, which requires a lot of data. It's ultimately not something that you can scale because it takes so much work to get a case rate agreement with each payer. But I suspect, a big part of what we're trying to do is publish as much as we possibly can on this work to move the policy conversation forward and get to a place where there are fee-for-service codes that you can use for these technologies. But that is far and away the biggest barrier right now.
Yeah, I would add, Sam, as you know, I've been working on this in an independent startup, and it does feel to me like the work that you're doing actually helps to move more payers towards a value-based approach because they can see that there's something worth paying for. There's an actual definition of quality. It's going to be very hard to ever be able to innovate in a fee-for-service environment. And what we're going to need is the kind of data you've got to be able to really support that transition. I think that will happen as a matter of policy. It'll help to have the total cost of care numbers as you get those. It'll help to get a better sense of the unit cost that you're getting now. But the key is going to be having a very clear way to define what value really means here and to make that not a huge burden to either patients, providers, or at the end of the day, to the payers. There's another question which I think we should talk a bit about it, which is you're relying on the PCP, right, to do some of the work here. Charles Krause asks about notification fatigue with PCPs. Are they just getting to the point where they say, we don't have time for this?
So notification fatigue is absolutely a real thing. And again, this is why you work hand in hand with an implementation scientist. We have worked super hard to make this minimal clicks. We created a bunch of feedback groups from PCPs so that we could hear firsthand from them what was working, what wasn't working, where was the pain. And we knew we had gotten it right when a bunch of PCPs told us, I can do this faster than writing a script for an SSRI. But the key is absolutely making it something that when that notification pops, the PCP, instead of seeing burden, sees an opportunity to do a thing faster than they might otherwise do it.
And if I may add, the approach that we took when we were moving from having the clinical decision support tool was initially a tool that was only accessed by somebody who chose to click the button and then look at it and interact with it. So we started without having any kind of active prompting, and we did that within the behavioral health setting where Sam's team of triage clinicians were interacting with the tool and then accepting or rejecting its recommendations as a way of us validating that the tool's logic was sound, but also understanding the patients for whom they were considering precision behavioral health and then referencing the tool. That gave us a data set that we were able to use to then do silent testing to say, okay, we have some understanding of the criteria that we should be using to determine when we are actively prompting consideration in primary care, and ran that data silently to understand what the prompting volume and burden would be prior to bringing it live. And that allowed us the data behind the scenes to titrate those decisions in a much more thoughtful way so that we could have a high degree of confidence in the specificity and sensitivity of that alerting mechanism before it was brought live.
Yeah, so that actually is part of what Rebecca Price is asking in this third question, which is the development of that algorithm to get those 3 recommendations to the PCP. What is that process? What did that require?
It was quite a lengthy process, and it really started with a grounding in clinical judgment. And so our initial sort of alpha ecosystem contained a bunch of tools, and every single one of about 20 integrated triage clinicians demoed every single one of the tools in that ecosystem. And we really started by just setting them free to use their clinical judgment with patients that they were triaging and make determinations about what technology they might recommend and for whom. And our first algorithm was really built to mimic their clinical judgment. And so after a year of running this, learning all about how to get patients connected, et cetera, we then built the first algorithm. Then we ran it for almost another year with those same triage clinicians to make sure that they felt confident in the recommendations that were being given. And then we started to iterate using more of the data that we had. And as we added more tools, we created more of a rubric around how you build out that algorithm. But it is all grounded in the clinical judgment of those triage clinicians to begin with.
Yeah, that's helpful to know. We've got just a couple of minutes left, and I wanted to give you each of you maybe a minute to summarize. You've started by talking about the problem as you saw it, what you tried to do to address it, kind of where we are currently with the data that you've got. I like this way of framing this as a learning health system, Sam. I think that's a great way to put it. Maybe we'll start with you, Georgia. In terms of summarizing what you've learned in this thing, what do you think is most important for this audience to hear?
So I think that building a case to a payer audience with the payer's pain points in mind is essential. They, of course, want to focus on extending access to patients to services that will make a difference to their members, but have to do so in a thoughtful way that is balancing the cost with the value. And so I think when thinking about recommending approaches to pilot or innovate, you both have to have a theory of the case of how you can at least get to a cost neutral proposition for payers to be willing to take that innovation risk, or find another body of funding that's going to allow you to build a novel data set that helps to make the case that you're doing something truly different. The approach that we took here was to both build a more classic business case and then to fund the initial proof of concept through that innovation arm, to make sure that by the time that we had a formal pitch to a payer, we would have all of the data that we understood they needed. So I think building backwards from that understanding of what a payer expects and what information they will need in order to judge a coverage decision is necessary to drive how you actually focus on product development.
Great. Sam, last comment. We've got about half a minute.
I will make a very brief comment, which is to say mental health systems of care and mental health clinicians need to embrace a data-driven approach. Our patients deserve the right to have what we do measured and shown to them in terms of the quality of the work we provide. And we deserve to get recognition for the tremendous work that we do. But the only way that we're going to be able to do that is if we really fully embrace complex, precise data collection as part of routine care. It is an absolutely critical part of your work. And if you are interested in learning a little bit about it from the perspective of a clinician, I cannot recommend enough 2 articles from Tony Rousmenier in The Atlantic about measurement-based care for clinicians.
Great. Well, thank you both. I think this is a great overview of a really interesting experiment that's already bearing fruit. It's a great model for all of us to learn about. How we scale it is going to be a challenge, but I think all of us are trying to figure that out. Thanks to the audience for listening in for these great questions. And we'll wrap it up at this point. I'm sure if people want to know more, they can reach either one of you, and certainly go through the society to learn more as well.
Thank you for moderating, Tom.
Appreciate
You
it.
bet. Take care.